welcome. I'm Linda Freed, and I have the honor of serving as the chair of the selection committee for the Frank A. Calderon Prize in Public Health. And today I have the honor of welcoming all of you on behalf of the selection committee and on behalf of Columbia's Mailman School of Public Health, which has the honor of serving as the home of the Frank Calderon Prize. Through the generosity of Dr. Calderon's family, since 1986, our school has had the privilege of awarding the Frank A. Calderon Prize in Public Health with a distinguished selection committee, awarded to individuals who have made transformational contributions to public health and represent the importance and impact of our field for all of us. Let me start by telling you about Dr. Calderon. He was raised and educated here in New York City, where he graduated from Columbia College. He then went on to earn his MD from New York University and his MPH from Johns Hopkins. He joined the New York City Department of Health, embarking on a career in public health leadership that would last his entire life. He served New York City until 1946, when he joined the World Health Organization, where he was instrumental in shaping the WHO's policies and initial structure. He later served as medical director for the UN Secretariat Health Service. We're truly honored to be part of Dr. Calderon's legacy and grateful. I'm deeply grateful, and we're deeply grateful for the friendship and collaboration of his family. The Calderon Prestigious Prize has been awarded over the years to impactful leaders in public health whose career contributions and ongoing impact have substantially affected the health of the public. This year, we award the Frank A. Calderon Prize in Public Health to Dr. Julio Frank, the president of the University of Miami. I will be introducing Dr. Frank shortly, as will Francesca Calderon. In addition to the Calderon Prize, Columbia's Mailman School also awards Calderon Junior Faculty Prizes, which support cutting-edge research innovation by junior faculty. And I believe that some of the junior faculty who've gotten that prize may be here. If you are, please stand up and take a bow. Anybody? Not yet. So it's my great pleasure to have Francesca Calderon-Steichen and her daughter, Frank Calderon's granddaughter, Ariana Stammer, with us. Because of the generosity of the Calderon family, the prize is now been increased in its value, consistent with the stature of the awardees, to a prize amount of $50,000, and we are very grateful. Thank you. Francesca Calderon-Steichen has been a true partner to our school and has become a dear friend. Since receiving her master's in public health a few decades ago, Francesca Calderon-Steichen has worked at the grassroots level to improve health and well-being for many. For a number of years, she was the program director and elder advocate for frail homebound senior citizens in 13 Princeton area communities. She also worked with the Medical Center at Princeton and most recently advised 2 municipal health departments in Mercer County, New Jersey. Her generosity and service extends to other fields as well. She helped to create the Edward Steichen Award, which is administered in Luxembourg and has become an important prize for young European artists between the ages of 25 and 35. Ariana, her daughter, who joins us here today from UNESCO in Paris, currently holds a leadership position at UNESCO, making her the third of 3 generations of Calderons in public health. So now I'd like to invite Francesca Calderon to the podium.
It is always a great occasion for me when I come into the city to participate in a Calderon Prize event. I have been doing this for over 25 years now, and although I may be going older and a little bit creakier, this very special occasion has not. I'd like to start by telling you a quick story about my father's sailing days. Over the course of a few summers, he and my mother used to take their old Alden schooner up the coast of Maine and on into Nova Scotia, Canada. Since the further north you go, the more treacherous the waters, my father would recruit 1 or 2 young midshipmen from the nearby Kings Point Merchant Marine Academy to act as his crew. The superintendent of the academy, a formidable man by the name of Vice Admiral George Gordon McClintock, sent him bright young men who were strong and able, but who needed some hands-on maritime experience. And what with rough Atlantic seas, deep fogs, heavy waves, and occasional storms, they certainly got it. Remember, there were no electronic navigational aids in those days. You used charts, compasses, and sextants, and in heavy fogs, you listened very, very carefully if you were near dangerous shoals for the sound of bellbuoys. My father was a superb sailor, but he also loved to teach. So he would try to pass on his maritime wisdom to these young men. They would return to the Merchant Marine Academy in the fall, lean, tired, and sunburned, but with a great deal more knowledgeable and practiced in the ways of the sea, having gained their knowledge through real-world experience. And may I say, my mother raised a bunch of girls, and she said that she fed them 3 meals a day, but in between meals she had to break out vast quantities of peanut butter and jelly sandwiches. The point of this story is that we depend on the younger generations to help us move the world forward, but we must give them the tools and the experience to chart their course. It is something my father knew well and practiced, and it is for this reason that I requested the honor of recognizing all our Calderon Junior Faculty awardees, those who are here and those who are not, because these awards are, in a very real sense, the first steps on the road to preeminent public health careers and perhaps, who knows, a future Calderon Prize. As for our current Calderon Prize recipient, I will leave it to Dean Freed to formally introduce him, but I would like to say to Dr. Julio Jose Frank Mora that you hold a very special place in my heart, not only because you are a Calderon Prize recipient, but because you come from a country that provided me with extraordinary experiences and memories when I was a young girl. Along with a small group of other girls, I was privileged to spend 2 summers in Oaxaca, Mexico in the 1950s. With our ethnologist hosts, we visited tiny Mixtec and Zapotec villages where we would spend the day sharing food and song and dances. We would go to the Zocalo on Friday nights where by tradition, at least in those days, the girls walked in one direction and the boys in another. We attended folk dance festivals, we learned to weave and to embroider, and we were even serenaded one moonlit night by some handsome young men who stood on the street under our windows and gently woke us up with their beautiful songs. Ay de mi. What I received from these 2 summers in Mexico was far, far more than I ever gave, and I have been grateful ever since. And it has been on my mind that the small bridges we built as young girls so many, many years ago were far superior to the walls some are trying to build today. And I am hopeful we will get back to that better place soon. So I thank Dr. Frank for his work, for his country, and for his wonderful people, and for accepting the Calderon Prize in this year, in this place, and at this time. And now, before I leave the podium, I have been asked to introduce the Dean of the Mailman School of Public Health, Dr. Linda Freed, This is a particular privilege and pleasure for me, since Linda is not only a friend and a colleague, she is an internationally renowned scientist, geriatrician, and public health leader. She has been profiled by the New York Times as one of the top scientists in the world, and was also cited by Thomson Reuters as among the top 1% of the most influential minds of the last decade. She is the recipient of numerous honors and awards, including the French INSERM International Prize for Medical Research, and she is an elected member of the National Academy of Medicine. Dr. Freed is preeminent in her field and in the hearts of the Calderone family, and I am grateful for the leadership she has provided in keeping this prize at the forefront of the public health arena, and for her seminal achievements in the fields of medicine and public health, work which has focused on helping all of us establish bases for longer and healthier lives. Et voilà.
Thank you, Francesca. That was very nice. Francesca, with this award, your family has brought something to all of public health, as well as to our school, that I believe is of enduring value as well as importance. Your vision has been to recognize the eminent leaders in public health who unite scholarship and values-based leadership to great impact. Before introducing Dr. Frank, I'd like to thank our selection committee, which consists of prior awardees of the Calderone Prize, as well as a number of other people. And representing the selection committee today, along with myself, is Dr. Laura Magana, who is here. Laura is the president and CEO of the Association of Schools and Programs of Public Health, and I'm deeply grateful for your participation and partnership. Thank you. So, to the surprise of no one, the recipient of the 2018 Frank A. Calderone Prize in Public Health is Dr. Julio Fronk. Dr. Fronk, as many of you know, has had an exemplary career in public health policy, leadership, research and practice, and education across multiple sectors and multiple platforms. Throughout his career, he has been committed to addressing the root causes of health inequity, and his work has led to significant changes in health systems, in public health education, and in public health leadership excellence. Much like Frank Calderone, Dr. Fronk started his career by serving his community. A public health trained physician, he founded Mexico's National Institute of Public Health using a unique model of both science and education, while also positioned to provide policy advice to the Mexican government. He also led the incorporation of the National Institute of Public Health in Mexico into the Association of Schools and Programs of Public Health as the first institution outside of the United States to become a member. Also, like Frank Calderone, Dr. Fronk spent part of his career at the World Health Organization, where, as the Director for Evidence and Information for Policy, he helped expand the evidence base for global health policy. He subsequently became Minister of Health of Mexico, where he led the reform and transformation of the Mexican health system, providing comprehensive universal health coverage that expanded access to medical care for more than 55 million previously uninsured people. He went on to serve as Global Health Advisor at the Gates Foundation, and then became the Dean of the Harvard T.H. Chan School of Public Health, although it wasn't the T.H. Chan School when he first started, where he served from 2009 to 2015. Preparing future public health leaders has been an area of great importance to Julio. He co-led the Lancet Commission on Health Professionals Education for the 21st Century, which galvanized medical, nursing, and public health education reforms in the U.S. and in many countries around the world. During his tenure, Julio launched several other major initiatives, from providing public health advanced leadership for health ministers to the development of innovative DRPH program in public health leadership, to the development of multiple massive online courses that brought public health knowledge to millions. Now, as president of the University of Miami, Julio continues to advance the art of teaching and the science of learning. His work there includes establishing the Hemispheric University Consortium and Hemispheric Innovation Hub, two large visions which I think all of us are entranced by. With compassion and commitment, Dr. Frank has truly changed public health policy, education, practice, scholarship, and the opportunity for health equity around the world. On behalf of the Selection Committee, we're honored to award you, Julio, the Frank A. Calderon Prize in Public Health. I invite Francesca Calderon-Steichen and Ariana Stammer to return to the podium and ask Dr. Frank to join us to receive the Frank A. Calderon Prize in Public Health. And now, Julio, it's my pleasure to turn the podium over to you.
Thank you. Good afternoon, dear colleagues and friends. It is truly an honor to be the recipient of the 2018 Frank E. Calderon Prize, which celebrates the inspirational life and legacy of a towering figure in public health. I want to start by thanking my, as you just saw, dear friend, Linda Fried, the Calderon family, who I've just had the honor of meeting, and I immediately feel, I already knew that Dr. Calderon was a sort of this legendary figure and a kindred spirit, but now seeing members of his family is just incredibly rewarding and very moving to hear the story of how paths interrelate and how biographies that we think are not related in the end up having these common threads that you so beautifully, Francesca, outlined. I want to, of course, thank the Selection Committee for this very generous decision. It has been 3 years since I started my life as president of the University of Miami, and I feel really privileged to return to my academic roots in order to receive an award from a school that has made so many fundamental contributions to public health. It is an additional honor to add my name to the list of outstanding individuals who have received this prestigious prize, most of whom have been admired friends and role models for me. As you know, and you just heard from Dean Fried, the explicit purpose of the Calderon Prize is to honor individuals who have made transformational contributions to the field of public health. When I read this statement, I was even more humbled by the decision of the jury. I was trying to think, what transformational contributions have I done? So I felt urged, this humbling feeling urged me to identify elements of my career that first could be considered contributions to my professional field, and second, which would be of interest to revisit in this lecture for the award ceremony. So I came up with 2 big topics which are closely related, namely my work to develop a new public health agenda and my contributions to the study of the health transition, that is to say, the long-term patterns guiding the remarkable transformation in the epidemiologic profile of populations and in the complexity of health systems. I do not intend to repeat ideas that I have discussed at length in the different academic and policy settings where I have had the privilege to participate. Instead, I will use these ideas as a reference to examine the evolution of health systems around the world. In that context, I will address an emerging and worrisome trend, which could be called backward transitions in healthcare. And that's why I've titled this lecture, Health Transitions, Progress or Paralysis. Now, I'm not going to use PowerPoints. I'm going to give you a PowerPoint break. Most people appreciate that. But it means actually that you need to pay attention rather than watch the graphs and the fancy figures. You need to pay attention. I hope you will enjoy it. After the end of World War II, most societies adopted a mindset of linear progress. The idea that the victory over totalitarianism and the continuous advancements in science and technology would bring uninterrupted improvements in social organization and in the human condition. Several recent processes, such as the spread of terrorism, xenophobia, hate crimes, and authoritarian populism, are questioning this extended belief and reminding us that progress is rarely unceasing. It can experience setbacks and regressions. This reality, I think, makes my lecture today particularly timely, even though some of the underlying concepts have evolved over a career that now spans 3 decades. So let me start briefly from the beginning. My professional journey began with the decision to study medicine, like the 3 generations of Franks before me. However, unlike my great-grandfather, my grandfather, and my father, studying medicine is a genetic risk. Unlike those 3 generations, when I finished my basic medical training, I decided not to follow a career in clinical care, but in public health, to make the whole of society my patient, as it were. I headed to the University of Michigan in Ann Arbor to study under the mentorship of Avedis Donabedian, who, by the way, began his pioneering studies about the quality of healthcare here at Columbia. If I were to summarize what Avedis taught me, I would say 2 things. First, he nurtured my ability to think in a rigorous way, whether to design a research protocol or find a solution to a policy problem. And second, he inoculated in me the passion for linking ideas to action. Thanks to him, my entire professional life has been guided by the conviction that rigorous thinking is a requirement for effective action. Unlike the way we very often are taught in our Cartesian framework that one thing is the world of ideas and another thing is the world of action. Actually, I do believe that rigorous thinking is a requirement for effective action, and there is too much action that is not thoughtful, that is not based on ideas. And Avedis was exactly my mentor in that whole mindset. After finishing my graduate studies at Ann Arbor, I returned to Mexico, where I joined Guillermo Soberon, a progressive and innovative minister of health, in an effort to build a new academic institution. By the 1980s, Mexico had excellent research institutions in the medical field, but none devoted to public health. The newly created Center for Public Health Research would produce essential evidence that could inform scientifically rigorous policy decisions. The center made major contributions, and after a few years was elevated to become the National Institute of Public Health. Today, this institute is one of the leading academic organizations in the developing world, as exemplified, as Dean Freed just mentioned, by the fact that it became the first non-US member of the Association of Schools and Programs of Public Health. And in fact, Laura Magaña, who's now the president and CEO of the association, was just immediately before that the secretary, the leader of all the educational programs at the Institute. So, you see, we even export CEOs to the association. I, on my part, many years before Laura, had the privilege of being the founding director of both the center and then the National Institute of Public Health. But what I would like to emphasize is that the design of these institutions was based on an explicit conceptual framework about the essence of public health, which served to orient both research and graduate training programs. The core ideas of this framework were published in a 1993 article with the bold title, The New Public Health. There I tried to define the elusive concept of public health. And we proposed a very parsimonious construction where, the two words are public and health. So public, this problematic adjective, refers in this parsimonious formulation specifically to a level of analysis, the population level. And health refers to two objects of analysis. And everything we do in health is focused on one of these two. On the one hand, the health conditions of a population. And on the other, the organized social response to those conditions, which in modern societies is structured through differentiated and increasingly complex health systems. Building on these ideas, I became interested in developing a dynamic understanding of health processes through the overarching concept of the health transition. And corresponding to those two objects of study of public health, the health transition encompasses, on the one hand, the epidemiologic transition, which is the long-term patterns of change in the health conditions, that first object of study, the health conditions of populations. And second, the health system transition, which is the transformation of the organized social response to those health problems. Let's start with the changes in the patterns of disease, disability, and death that have taken place since the 20th century. These changes are so dramatic that they have been characterized as a health revolution. Its clearest manifestation is the doubling of life expectancy that took place during the 20th century, from a global average of 30 years in 1900 to about 68 years by the year 2000. Not only did the overall levels of mortality drop, but the dominant pattern of diseases and causes of death also experienced a tectonic shift. This is the process that the theory of the epidemiologic transition seeks to describe and explain. The original formulation of this theory by Abdel Omran in 1971 states that all modern societies eventually undergo a replacement of infectious diseases by non-communicable diseases as life expectancy increases due to better living conditions, disease prevention, and improved health care. According to Omran, countries move in the same direction, passing through identical stages, each of which has a dominant pattern of morbidity and mortality. In his view, there are three distinct models of the transition: the classical model, experienced mainly in Europe, the accelerated model, represented by Japan, and the delayed model, what he called the delayed model, present in most developing nations. Along with several colleagues at the Center and the National Institute of Public Health, we challenged this linear and unidirectional formulation by demonstrating that many developing countries experience what we called a protracted polarized model of the epidemiologic transition. To begin with, the stages suggested by Omran are not necessarily sequential. Two or more stages may overlap, generating what is now widely known as the double burden of disease. And that is that in most low and middle income countries, the unfinished agenda of common infections, malnutrition, and maternal mortality coexists with the rising prevalence of non-communicable diseases. And this is particularly acute in countries with high levels of social inequality. So that's why this becomes a polarized and a protracted model. Rather than new problems substituting the old problems, what you have is a pattern of juxtaposition of the old and the new. But in addition to this, the evolutionary changes in the patterns of morbidity and mortality are actually reversible and may give place to what could be called counter-transitions. The best examples are re-emerging infections, such as cholera, dengue, fever, and malaria. And some of these counter-transitions are present in countries at all levels of development, because with growing global interdependence, many of these reversals are due to the international transfer of health risks. Now, what about the other object of study of public health, the organized response to health conditions, the organized social response to health conditions? Is there a health system transition parallel to the epidemiologic transition? Alongside the spectacular reduction in mortality, there has been a second health revolution characterized by the emergence of diversified, differentiated, specialized, and complex health systems, which have become a dominant feature of the social fabric in all but the most marginalized corners of the planet. In fact, if you look historically, most of that social response was structured through undifferentiated institutions like the family or religious organizations that then provided care for the sick. It's only in the 20th century, although there are preliminary developments earlier, it's only in the 20th century that the main vehicle for that organized social response is through specialized, differentiated, and increasingly complex health systems. Today, taken together, health systems absorb 10% of the world economy. That's about $7.5 trillion per year. Now, there is one country that alone accounts for about 40% of that, and I will leave here the quiz of which country that is. But in the United States, it is the largest sector of the economy, employing millions of health professionals. Many of us here in this room are part of that. And we seldom stop to think how recent that phenomenon is. Even hospitals were, until recently, they were not therapeutic spaces. They were spaces where people went to die, mostly the destitute, the homeless. It is only, although again there were some initial developments since the 18th and 19th century, it is really as of the 20th century that hospitals become preeminent therapeutic spaces. Now, there are huge differences across the world. For example, if we look at health expenditures, while the United States spends every year close to $10,000 per person on health, many countries in sub-Saharan Africa invest less than $30. But in contrast to most of human history, today health systems permeate all corners of economic activity, dominate political debate, generate cultural interpretations, spur technological innovation, create deep ethical dilemmas, and accompany human beings at the most crucial moments of their existence, from birth to death. And yet, despite the revolutionary changes in the way that societies organize and finance the delivery of healthcare, we don't have anything that resembles a theory of health systems transition. As has been said so many times, there is no other industry of this size that spends so little in understanding its dynamics, evaluating its own performance, and learning from its best and worst practices. I have spent a good part of my professional life trying to develop coherent, comprehensive, and comparative ways of thinking about health systems. Time does not allow me to discuss the insights that I may have gained through this effort. Suffice it to say that among the many innovations in this arena, 4 stand out as truly transformative. The first one is the notion of access to healthcare as a right. Indeed, most countries have amended their constitutions or approved laws to explicitly recognize healthcare as a social right, and have used these legal frameworks to expand access to comprehensive services. The second transformation refers to the organizing principle for health systems. As they seek to expand services, many countries initially segregate different population groups based on their income or labor market status and create separate healthcare arrangements for each. However, in a growing number of countries, such segmented systems have been superseded by universal arrangements. And I use the word universal in its double meaning. First, a system that covers every person, and second, very importantly, that does so with equivalent rules and entitlements. In that sense, universal is the opposite of segregated. It's not just that it covers everyone, but it does so with similar entitlements. Instead of organizing the health system by population groups, for example, by setting up different arrangements for the poor or for salaried employments, truly universal systems are organized by the cross-cutting functions that apply equally to everyone. And in my own writing, I think of 4 big functions. Stewardship, which includes the rules, but it's the strategic direction, also obviously the regulation, who can practice a health profession, what do you need to license a hospital, what drugs may be sold in a country. Stewardship includes that, but also the evaluation of performance and other strategic functions. Second function, finance, the mobilization and allocation of resources. Third, the delivery, the core, the delivery of services, whether personal health services or public health services, the core function of the health system. And then fourth, resource generation, creating the human resources, the facilities, the technologies that actually power the health system. So that's the second big trend. Instead of segmented by populations, health systems that are moving towards a universalist framework start organizing by functions, with different agencies doing each of the functions with equal rules and equal entitlements for everyone. The third paradigm shift refers to the search for integration according multiple dimensions that have been traditionally treated as false dilemmas. And we have lots of those in health. Prevention versus treatment, primary care versus specialized care, vertical versus horizontal programs, infections versus non-communicable diseases, local versus global, knowledge versus action. A particularly relevant effort at integration has emerged with the concept of population health. In its best usages, and there are other usages, but in its best usage, this notion points to a potential connection between clinical care and public health. In particular, high-performing health systems realize the synergies between extending access to care and acting on the upstream social determinants of health. It's not a dichotomy, it's not a dilemma. Good health systems do both, provide access to high-quality personal services, but also act on the upstream services. And in fact, efforts to extend insurance can only be financially sustainable if they are accompanied by vigorous actions to stop people from getting sick in the first place. Finally, the fourth transformative innovation refers to the systematic adoption of mechanisms to promote transparency and accountability. Salient among them are anti-corruption efforts in countries at all levels of development, along with the slow but consistent introduction of procedures to evaluate programs and policies. This way, we can build a body of knowledge about which reforms work under which circumstances, thereby enabling a process of shared learning across countries. After a quarter of a century thinking and writing about complex health systems, I had the rare and precious opportunity of actually applying all that I had learned. In the year 2000, at a historic juncture following the first fully democratic election in Mexico, I was appointed Minister of Health there. The first thing I did was to place at the center of my desk a card with a quote from Winston Churchill, which served as a reminder of my responsibility every single day of my 6-year tenure. The card said the following, and I quote, "To each, there comes in their lifetime that special moment when they are figuratively tapped on the shoulder and offered the chance to do a very special thing, unique to them and fitted to their talents. What a tragedy if that moment finds them unprepared or unqualified for the work which would be their finest hour." End of quote. I read that every single day. My very special thing was to introduce a program of universal health insurance in Mexico. Again, there is no time to describe this reform in any detail. For those who are interested, I can say that given my own commitment to evaluation, the Mexican experience has spawned a substantial body of literature with over 120 articles in peer-reviewed journals and even several doctoral dissertations. For our purposes today, suffice it to say that this reform was a textbook case of evidence-based policy. Indeed, a series of careful studies had revealed, like in many other countries, by the way, had revealed alarming rates of catastrophic health expenditures as a result of the fact that approximately half of the population, 50 million people then, lacked insurance. This analysis brought to light an unacceptable paradox. We know that improving health is one of the most effective ways of fighting poverty. Yet medical care can itself become an impoverishing factor for families when a country does not have the social mechanisms to assure fair financing that protects the entire population. In 2003, we secured support from all political parties for legislation aimed at correcting that paradox. The vehicle for doing so is a public scheme called Seguro Popular, funded predominantly through federal and state subsidies. By 2015, over 55 million people were enrolled in it, and the country was on track to achieving the goal of universal coverage. The benefits of this reform have been documented both in specialized journals and in publications aimed at a broader audience. For instance, the influential magazine The Economist recently featured Seguro Popular in a cover article on global efforts toward universal health care. This was the main conclusion of that article, and I quote, "Studies," and here I guess they're referring to the 120 peer-reviewed studies, "studies suggest that Seguro Popular has drastically reduced the number of Mexicans facing catastrophic health costs and reduced infant mortality." End of quote. The Mexican reform applied the 4 health system transformations discussed earlier. Several other countries around the world have also done so. The key question now is whether such elements of progress are irreversible or whether there is a risk of backward movements. As in the case of the epidemiological transition, can health systems also experience counter-transitions? Recent events show that ideological preconceptions and short-term political interest can distort what experts may optimistically consider to be the natural evolution of public policies. A prime example of this risk is offered by the repeated efforts to repeal the key provisions of the Affordable Care Act. While this legislation did not include all elements of the health system transition that I described, it did represent a major step in the right direction and was improving insurance coverage, especially among the poor in the United States. It is estimated that the recent actions by Congress and the administration could leave 18 million Americans without coverage this year and 32 million more by 2026. If such a reversal is not itself reversed, the United States will continue to stand out as the single developed country without a universal health system. Mexico is also at risk, now that it has recently joined the global trend to elect populist governments. If there too ideology replaces evidence in the formulation of public policy, Seguro Popular could be in jeopardy despite the evidence of its benefits mentioned before. What these cases illustrate is the fact that progress in health policy is not linear. It has ups and downs, forward-moving stages, and reversals. We tend to believe that the improvements and institutions brought about by enlightened policies speak for themselves, that they are self-preserving because they have proven their worth, that they have a sort of shield that guards them against biased and narrow-minded attacks. This is simply not true. No matter how well they performed, we should never take programs and institutions for granted. We should always try to improve them, but we must also protect them actively. The first half of the 20th century suffered from the actions of authoritarian leaders willing to destroy what had been built gradually with enormous efforts. It is now obvious that the 21st century will not be exempt from this exact same type of risk. In such turbulent times, the role that universities play in society is becoming more important than ever. In my current position, I often reflect on the need for universities to be exemplary institutions. By this I mean that through the values they embrace and the behaviors they exhibit, universities can be an example, a model or an example for the larger society of which they are a part. We do that, for instance, when we demonstrate that it is possible to engage in civil and civic discourse to process disagreements in a respectful way, which seeks to understand rather than dismiss differing points of view. At a time when the credibility of institutions and expertise is often questioned, we become exemplary as we uphold the value of basing decisions on rigorous evidence rather than ideological prejudice, and as we reaffirm our commitment to the pursuit of truth, no matter how complex and contradictory that pursuit of truth may be. We still hold our statements to standards of evidence about the validity of what we say. There is no question that our societies urgently need to bridge the painful divides that fracture us along economic, educational, ethnic, and cultural fault lines. To do so, universities must continue to serve as the most legitimate engines of opportunity and upward social mobility. While progress is not inevitable, paralysis is not an option. Our efforts to keep advancing cannot falter. As engaged members of the Commonwealth of Universities, we have no choice but to persevere in our pursuit of knowledge as the most powerful force for enlightened social transformation. I thank you again for selecting me as the 2018 recipient of the Calderon Prize, which honors the achievements of public health professionals and encourages all of us to continue striving for progress. Thank you very much.
Dr. Frank, that was perfect in both inspiring us and showing us why you are the right 2018 recipient of the Calderon Prize. Thank you. I'd like to invite everybody to join us in room 401 for reception. We hope you'll come upstairs. And I want to thank the selection committee and the Calderon family and all of you for being here to recognize a truly exemplary leader. Thank you. One correction, the reception is in the lobby. I was misdirecting you.